In this lesson, we will determine a general approach to the patient with hypo or hyperglycemia. Acute derangements in glucose are common endocrine-related complaints requiring management in the emergency department. Consistency in approach can help clinicians identify critical issues and can lead to a straightforward treatment methodology. Type 2 diabetes mellitus is the predominant form of diabetes. It is a metabolic disorder characterized by hyperglycemia and associated with the relative deficiency of insulin production, as well as a reduced response of the target tissues to insulin. Due to diabetes-related macrovascular complications, patients with diabetes are at a greater risk of morbidity and mortality than non-diabetic individuals. The risk of cardiovascular disease, including heart attack and stroke, is 2 to 4 times higher in diabetics. Diabetes is the leading cause of adult-onset blindness and also accounts for the majority of chronic kidney disease and non-traumatic amputations in the United States. Relative insulin resistance causes target cells to struggle with glucose uptake, and because the liver has a relative insulin resistance, it fails to regulate gluconeogenesis and glycogenolysis. Patients may present to the emergency department complaining of elevated glucose levels, decreased glucose levels, or complications of chronic diabetes. All of these bear mentioning. Complications will be covered in a future lesson. In patients complaining of hyperglycemia, hydration and IV insulin are the mainstays of care. Intravenous insulin is preferred over subcutaneous insulin because it can be inconsistent in a volume-depleted patient. Volume repletion, IV regular insulin, correction of electrolyte imbalance, and specific therapies directed towards any underlying cause of hyperglycemia are the components of treatment. Subcutaneous administration of insulin in non-volume depleted patients is acceptable. Typically, an initial bolus dose of 0.1 to 0.15 units per kilogram IV or subcutaneous of regular human insulin or insulin Lispro is given, which may be repeated in 1 to 2 hours if glucose levels have not fallen at least 50 milligrams per deciliter. In a pinch, such as times of drug shortage, Lispro may be given in a similar manner. Hypoglycemia can be treated in a variety of ways depending upon the mental status of the patient. Patients who are alert enough to tolerate oral intake can be given a glucose-containing beverage followed by a meal. Those without the ability to cooperate with oral intake should be treated parenterally. Options include D10 or D50. In either situation, administer 25 grams of glucose. Anecdotally, patients prefer a gentler approach with D10 given over a few minutes as opposed to the rapid change seen with D50. However, in the arrest or peri-arrest or unstable patient, D50 is the mainstay. Another option is to provide IM or subcutaneous glucagon. Keep in mind that it relies on hepatic glycogen stores, so this may not be effective in patients who are malnourished or who are alcoholics. If hypoglycemia is suspected as a result of a sulfonylurea, octreotide may be given to suppress insulin secretion. Its use should be reserved for patients who do not appropriately respond to the administration of dextrose. A general rule of thumb is that if hypoglycemia is due to sulfonylureas or non-short-acting insulins, patients should be admitted for serial glucose monitoring and treatment. In the case of both hyperglycemia and hypoglycemia, it is important to ask why. Sometimes the answer is medication noncompliance, but it's not uncommon for some other form of physiologic stress to be at play. Make sure to take a good history and complete a thorough examination and let that guide your workup. For Team Health, I'm Dr. Patrick Cody. Thanks for watching.